Welcome to the SIBO Doctor Podcast with Dr Nirala Jacobi, a US-trained naturopathic physician and director of SIBOtest.com, an online breath testing service and education portal for practitioners. In this podcast series, medical experts join us to discuss functional digestive disorders, clinical practice, and research as it relates to small intestinal bacterial overgrowth and associated conditions. This podcast is intended for SIBO treating practitioners and aims to help educate how we may best serve our SIBO patients. If you're a practitioner and want to learn more about SIBO, head over to the SIBO Test Education Portal where you can sign up for courses, masterclasses, and group mentoring sessions to expand your knowledge for successful treatment outcomes. If you're a patient, please know this information is not intended to diagnose or treat a medical condition. Please ask your doctor before initiating any new treatments. And now, over to Dr. Jacobi and the SIBO Doctor podcast.
If you're like me, you're finding that treating small intestinal bacterial overgrowth can be complicated. Patients often present with a myriad of symptoms and associated conditions which require holistic thinking and a methodical approach to treatment. This podcast was born out of a desire to start a conversation with other practitioners, educators, experts, and researchers, and see if their insights can give us new treatment considerations, especially for our difficult cases. In this podcast series, our guests talk about functional gut disorders, hormonal issues, the enteric nervous system, food intolerances, the immune system, the microbiome, methylation and genomic issues, and everything else that can make a SIBO case very confusing. I believe that by understanding the often complex interconnection of SIBO with other disease manifestations, we can be more effective in our treatment approaches. I hope you find this podcast useful in your practice, and thank you for listening. Welcome, SIBO practitioners. Today I have in conversation with me Dr. Christopher Shade, who is the CEO and founder of Quicksilver Scientific, which it's a lab that specializes in the biological, environmental, and analytical chemistry of mercury and all its forms and their interactions with sulphur compounds, particularly glutathione and its enzyme systems. He's actually patented analytical systems for mercury speciations, and we'll talk a little bit about that later on. But one of the reasons why I've wanted to talk to Dr. Shade today is because I went to the Bioceuticals Research Symposium earlier this year in Sydney, and he was giving this riveting presentation that my little naturopathic soul was singing when I heard words like emunctories and intestinal detoxification, and I thought it was really relevant to what we as practitioners often see with advanced cases of SIBO where there's a lot of dysregulation. So I'm really happy to welcome Dr. Chris Shade to this conversation. Welcome, Chris.
Thank you. I'm very happy to be here. It's good to talk to you again after the symposium. I'm glad to talk more about this because I've become obsessed on liver, gallbladder, GI connection and getting them all lined up as a way to clear a lot of problems in people.
Great. And it's, you gave like a day-long workshop where that was divided into different groups. So we'll basically just be touching on different things. But for those that want more information, I think you actually have a lot of also information on the Quicksilver website. Is that right?
Yeah, we have a lot there, and there's a lot we have a YouTube channel, and I think I've done 25 different webinars there, and you'll find, especially the last 3 or 4, where I'm talking specifically about liver, gallbladder, GI connections, and how we set up detox, and how failure to move bile is really at the heart of what we call detox reactions. And I think it's a core part in things like SIBO because you have to start thinking about bile as a detergent, because it is a detergent and it's cleaning the upper small intestine. It's not supposed to have much bacteria up there. And so I think failure to move bile is not just a detoxification problem, but I think it's a core problem in SIBO.
I do too. I mean, we look at it more not as far as that bile is not moving, but that bile acids are actually being destroyed by SIBO bacteria. That's pretty common, and so we do see a lot of fat malabsorption. So more from a malabsorptive problem or issue, and also toxicity issue, because if you're dumping bile and you're kind of releasing toxins and not binding them or not getting rid of them, then I'm assuming that's also an issue. But yeah, I actually do see a lot of cholestasis and stuff as well with these patients. But kind of getting stuck into more specifically, I just found, like I said, I was just so riveted with this idea that the old pleomorphics and the eclectics talked about, which is emunctories. And a lot of naturopaths actually have never heard that term. I was just talking about it the other day. I was like, I'm so excited. I'm going to talk to Chris Shade, and we're going to talk about emunctories. And they were like, what? So we in America, we do know that. But if you can just elucidate a little bit more on the term, that'd be great.
Yeah, it's a tough thing. And unfortunately, and I hope I don't get too many people too angry, but the new naturopaths are really focused on sort of being MD-like, and they've lost some of the traditional training. And so it's funny being a PhD and bringing these things back.
I know, I loved it. I loved it. That's what it was. I just totally was like, oh my God, this is the best.
And so, the emunctories are drainage pathways. And you go back to the old European ideas of drainage, and in French it was called lavage, which also means washing, like you're doing the laundry, and it's washing the extracellular space. And so it's the movement of the lymphatics from the extracellular space gathering into lymphatics and then cleaning themselves out. Now, when you talk about drainage, you're talking about bioflow from the liver, you're talking about urinary flow out of the kidneys, but then there's all the gut-associated lymphoid tissue and all the clearance that happens through the GI tract, and really where I got my start. And I'll also preface it that I think a lot more of the lymphatic interaction is in the lower intestine than the smaller intestine, and the small intestine is more of this chemical reactor. That's where more of these transport proteins are. But I got my start by bringing in a specific metal binder for the GI tract. We call it IMD. Klinghart's group calls it microsilica. And I first started trialing that with old guys like Hal Huggins and Dietrich Klinghart, and it was a total missing link. It was way beyond what chlorella was doing. And, they would all talk about all the surface area that you have in the GI tract to do all this filtration from. So emunctories is all the drainage. In the liver, it's moving bile. And when I teach about moving bile, that starts in the hepatocyte, and it's PC that's starting this. It's being donated from the membranes into the bile flow, and then the bile transporters are aligned with and overlap with the toxin transporters. The things that are moving mercury, glutathione conjugates, or any of the toxin conjugates into the bile flow are also moving bile salts. And so those are called MRP2s, but right next to them are the BSEPs. So BSEPs move bile salts, and MRP2 move toxin conjugates and bile salts. So they're moving into the bile tree, and then that's draining into the gallbladder and then going into the small intestine. So there's a lot of opportunities at which what I call liver momentum can be halted. You can fail to have enough PC to fluidize the bile, and you create cholestasis there. That's a very easy way to do it.
So PC is phosphatidylcholine, right?
Yeah, so phosphatidylcholine, and we do all these liposomal deliveries using phosphatidylcholine, so that's good for that. And for years, PC has been used for liver health in German biological medicine. Patty Kane popularized in her PK protocol IV and oral PC, and it's long been established that just lack of choline will create cholestasis. So from inside the hepatocyte, the PC donation is sort of starting this. But then any inflammatory reactions, and specifically relevant to us here is excessive endotoxin or lipopolysaccharide. And we're getting that from the leaky gut from the SIBO. And so that's creating this inflammation in the hepatocytes that's blocking the biceps and the MRP2. That's blocking that flow across the basolateral membrane. That's the membrane going from the hepatocyte into the beginnings of the bile tree, the bile canaliculus, and then they're growing together. And then down at a gallbladder level, you can have where the gallbladder is not being stimulated, you're not having that vagal response, and you're not flushing bile out of the gallbladder, or you've got a buildup of what they call sludge in the gallbladder or actual stones in the gallbladder. And so there's all these places at which you can stop that movement of bile and toxins. And I think the most relevant thing that I brought to the table in the last year, and I was talking about that down in Australia, is that when that fails to happen, there is another door out of the hepatocyte that goes back into the blood. And so if you rev up, say you're taking milk thistle and some lipoic acid, and you're revving up phase 1 and phase 2 detoxification, but you can't complete on phase 3, which is the movement into the bile, then those conjugates are actually redirected into the blood. And where do they go from there? They go to your brain, to your skin, to your kidneys, to sensitive organs. And this explains the detox reactions when that's phrased as a negative thing. So those toxins are mobilized and then dumped back into the blood. So I think that's a super important thing, and we focused a lot on really getting that bile flowing with a combination of PC and really strong bitters.
Yeah, and so this backflow is basically an impairment in phase 3 then, where bile is not being utilized as a sort of carrier for these endotoxins. Well, first of all, let me just go back because there was so much in that what you just said. I don't know where to start. I have like
I'll give you a 10-hour lecture there.
I know you summarized it quite well.
Let's go back.
But just to finish my thought about that, just that last little bit is, so we can see detox reaction when phase 3 is impaired because those endotoxins or those conjugated toxins are no longer being dumped into the bile. There's backflow. So this is what the old people, like, that's why as naturopaths we've always treated the liver and other areas or other emunctories for things like skin condition. This is not news to us. So that's cool. Now let's go back to the very beginning of what you said, where LPS actually, did you say that it impairs these MRP proteins and therefore impairs phase 3?
Yeah, and LPS is doing so many things to us. SIBO is such a great condition because it's usually going along with a leaky gut. And so endotoxin, yes, it impairs phase 3 in the liver. And of course, a lot of what we're going to talk about are the neurological consequences of leaky gut, SIBO, of backfiring liver, where those toxins end up in the brain. But if endotoxin is causing a problem in the liver, endotoxin is also very responsible for initiating neuroinflammation and part of that is creating a leaky blood-brain barrier. So endotoxin is both creating the opportunity for the toxins to hit the brain and blocking that phase 3 from the liver into the small intestine.
Okay, good. So now, one of the things that what I love about a good presentation, and that's what I experienced when you did that, was how you kind of walked us through the different blockages to the different emunctories and what could happen. You can have an impaired kidney function, you can have impaired intestinal detoxification. So besides this mechanism that you just described with impaired phase 3 and also leaky gut and absorption of LPS, are there any other blockages to, and when you say intestinal detoxification, is that what you mean, or are there other things that you would include?
Well, that was like part 1 of several, and so, but that picture there sets the stage for all the other things that we're going to say. So let's put in the intestinal detox part off to the side, and it'll all make sense in a second. But now let's carry that example of the LPS blocking phase 3 from hepatocyte into the bile ducts over to the kidneys. All right, so the movement of, let's choose metals as a toxin. The movement of metals into the urinary flow has nothing to do with glomerular filtration, and that's what everybody measures for kidney function. The movement of toxins into the urinary flow is exactly analogous to the movement through the liver. There is a transporter called an OATP, organic anion transport peptide, that brings toxin conjugates from the blood into the proximal tubule epithelial cells. So if you remember the nephron, the unit of the nephron in the kidney, you have first glomerular filtration, a crude filtration of essentially plasma, and that there's a lot of it. There's 5 or 6 times more that's filtered there than what comes out in the urine. And then it goes through the proximal tubules, and there's a winnowing that takes place. We're salvaging back things that we want to keep, amino acids, small peptides, minerals and such, and water. And we're pulling that back in. And at the same time, we're actively transporting things we want to get rid of. And so the toxins are actually in the proximal tubules, pulled from the blood into the proximal tubule epithelia, and then MRP2, the same transporter that's at the basolateral membrane of the hepatocyte, is moving that toxin conjugate into the urinary flow. And it gets blocked by a combination of endotoxin and metals really well. There were some animal studies where they showed that the metals alone and the LPS or endotoxin alone didn't really shut down that transport, but together they shut down that transport. So the same thing that can shut down the liver transport can also shut down the kidney transport.
So is that besides metals, because okay, so my question is with endotoxins, LPS, etc., will that, you just explained how it can shut down the active phase 3, which is also kidney and liver and elsewhere, but does it actually affect glomerular filtration rate, or is that more sort of volatile things like metals that will cause kidney damage and effectively reduce GFR? Or because I've never heard of endotoxins actually affecting GFR.
Yeah, so it's not GFR. Again, GFR happens in the glomerulus. And active transport of toxins happens in the proximal tubules.
I see.
And so the endotoxin is damaging the proximal tubules.
Okay.
So when you look at the testing that we do, where we look at inorganic mercury, that's the form that you get from dental amalgam. It goes, you inhale it, it ends up in the blood. You inhale the elemental mercury vapor, it turns to inorganic mercury salt. It's going through the blood. Some's going out through the kidney, some's going out through the liver, and we'll see where it's totally blocked going through the kidney, but GFR is still fine.
So, but you often see a double whammy when somebody has some sort of kidney dysfunction. So not only are they not able to filter the blood correctly, but when it does get filtered and they have SIBO, they might have some proximal tubule issue as well because of LPS, possibly.
Exactly. And you can see that damage before, that's my contention, is that you see the proximal tubule damage before you see the GFR damage. And so they can be independent of one another, or there could be things that damage both of them at the same time.
Is there a marker that you can look for on a test to check for proximal tubule function?
The mercury tri-test that we do is the only one that I'm aware of right now, because it's a toxin that is specifically transported through the proximal tubules. And there should be a ratio between what's in the blood and what's in the urine. We've figured out what that ratio is. And so when you see high blood but low urine, that's a failure to move through the proximal tubule. Now, in reality, there's probably damage to it, and there's probably SNPs. Now, people get all high and mighty about their SNPs. I know all about these SNPs, and they tell me whether I detoxify or not. And, I have this SNP, I'm going to die. But we're not looking at half of the SNPs that are out there. And so the SNPs for the transport proteins, everybody looks at glutathione as transferase, but nobody's looking at the transport proteins yet because they haven't moved, the promoters for them haven't moved into commercial use yet. And I'm very interested when we can get some of those, look at those SNPs. So when I see a bad urine to blood ratio, there's probably a combination of SNPs and damage, but I think the SNPs will be small changes and the damage are really deep changes.
Well, the other aspect, of course, that happens with impaired detoxification is inflammation, right? And so can you talk a bit more about the connection, how poor detoxification triggers inflammation and nerve 2 and all that?
Yeah, usually when I lecture, I'm lecturing it kind of flipped over, how inflammation is blocking detoxification. Because what is one of the greatest sources of acute inflammation but endotoxin, lipopolysaccharide? And when it brings inflammation up, it shuts down detoxification. So there's this problem that when people have chronic infections, they're chronically turning down detoxification, because detoxification is part of antioxidant activity. It's part of your whole set of genes for antioxidant and chemoprotective activities, whereas inflammation is pro-oxidant. You're making free radicals and peroxides and peroxyl radicals, hydroxyl radicals, hypochlorous acid to kill invaders. And what does endotoxin say to your body? It says to your body that you may have something like E. coli in your body, and you got to turn up pro-oxidative activity to kill things off. And when you do that, you suppress antioxidant and detoxification activity. For a long time, it was lectured that the poor detoxification was causing inflammation. And to an extent, that is probably true because the toxins are inhibiting the immune system. The immune system is allowing infections, and in the gut, your failure to detoxify is perhaps creating toxicity, which is causing leaky gut and can further drive inflammation. But I look at it more that once the inflammation started, the inflammation may have started the poor detoxification. But they're so intertwined that it's a little bit chicken or the egg.
Okay. Well, so just to kind of bring it back to the clinical level, because people probably are like, oh my God, I already, 20 minutes. Oh my God, there's so much here. So, because we often are, we all know about phase 1, phase 2 in terms of P450 and then conjugation, etc. But this phase 3 is really something that a lot of people will find new in a way. And so we do have ways to assess both phase 1 and phase 2, whether that's through genomic assessment or different challenging different conjugation pathways. But is there something that is a marker for poor phase 3 detoxification, or is it just something that you can deduce by somebody who has gallbladder issues, which I actually find are really common?
Yes. All right. Several things to say here, and one of which is that I do have good news. We're waiting to tie this together. I wasn't going to leave you in you're lost in the hell of the chicken or the egg, and you'll never know how to get out of it. I do have a solution, and in the solution, sometimes it doesn't really matter what started it. But we're going to have to drain things and open things up. And as you just said, what I'm finding is that the gallbladder issues, low functioning, under functioning or not functioning gallbladder is rampant. It is all over the place. And addressing just gallbladder and then having a good multi-toxin binder can take you so far in getting people better. Gallbladder is the first thing that I look at. Now, to back up a second, you said, do we have a test yet? there is no specific test. In the kidneys, the urine to blood ratios of our mercury test is going to show you something. I think it won't be long before we have some tests that we can do, but a lot of it, like a really good test, would test what's in the blood versus what's coming out in the bile. And unfortunately, collecting it as stool is messy, and all these things have happened by then, and it's gone through all this bacteria, and you really can't tell anything. So the best test would really be blood versus bile, and looking, at how things are moving through there. But in the absence of that, you can look, put on your naturopathic hat. Naturopaths have put on too much of a functional medicine hat and aren't looking as much as this, because you can start testing for everything, and then if you don't have a test for it, it doesn't exist. That's the downfall of testing. And I run a testing lab, so
I do too.
yeah, and so we know what the limits of our tests are. And there's limits. They're very helpful. They're helping to fill in this big paint by numbers picture, but then you have to fill in other things with your clinical assessment.
Exactly.
And so, of course, you ask, do you have a hard time with fatty meals? Do you get things that show up on the skin? Because going back to when the liver backfires, what are the most common things? After that, when they detox, they get really brain foggy or anxious. That's it going to the brain. When they're detox, they get skin breaks out. That's because it's not going through the bile, instead it's coming out through the skin. When they detox, they get lower back pain. That's when it's not going out through the bile, and instead it's hitting the kidneys. So you can ask these things. You can palpate the liver. A lot of them have diffuse pain through the liver. You can muscle test liver and gallbladder if you know how to differentiate the two. There's a lot of ways to look at it, and then you put them on really strong bitters, and you'll find that a lot of this really opens up for you. However, once we drain all that bile out, so when we started this picture of dysfunction, we said that when you can't go through the bile, it backfires into the blood and you have all these problems. However, if we do get the bile to drain and we dump all that into the small intestine, then you just dumped all these toxins into the small intestine. Now, if you got leaky gut, a lot of them are going to go back into circulation. Even if you don't have leaky gut, many of them, it's their natural path to come back into circulation. And all these toxins are going to bother the intestine. So you want to follow those strong bitters maybe 30 minutes later with a multi-specific binder. Multi-specific meaning multiple kinds of binders, so that you can get multiple different toxins, because there's never just one. So we use a combination of charcoal, clay, chitosan is derived from shellfish, but there's no allergen in it, and it's a molecular mimic for Welchol and cholestyramine, so it's a good biotoxin binder. And then some sort of metal binder, like in our products, we have one called IMD, which is very specific. If you can't get that, a bunch of chlorella will do that for you.
I've had my patients order the IMD, and it's like this, it's this tiny vial, right? Like it's
vial, but there's, there's
how the hell? Yeah.
There's enough metal binding capacity in that 6 grams to equal 3,000 chlorella pressed tablets.
Yeah. Wow. Okay. So, but because what we often look for, I usually when it's an active SIBO case, the last thing I want to do is further detoxify. I actually just support and improve inflammation in the gut before I would ever do that. But that the binders come in also really handy. I mean, I use a binder that is in the zeolite category, so it has different functions. But that's the other thing. Can we just talk about what different?
One is that?
That's the Toxiprevent.
Yeah, Toxiprevent. That's a really nice product. I like that a lot. And
I do, but it does cause a little bit of constipation, so I can't use it for those people that already are a little toxic from, that's the constipated people that are even more at risk for absorption of endotoxins. So, it's a bit of a tricky thing.
We use a lot of acacia gum to help lubricate and move that. You're going to have to use a number of different a number of different laxatives with it. But that toxic prevent bile is a very, very high dose. That's 3 grams in each one of those little sachets. They should be starting with a fraction of that with a lot of water. Again, if you can get acacia gum straight, using a lot of acacia gum, which is good for leaky gut, and it is good for GI health, and it's a slow, low FODMAPs prebiotic that's a bifidogenic prebiotic. So moving them up slowly. But I want to step back a second. Everybody's afraid to detox, but we need to break what detox means down into multiple parts. So when I'm starting, I'm wanting to just move bile and catch it. Now, if they're super hypersensitive, sometimes they even have reactions to the bitters. And so I'll just do PC, and we have a new, you're going to love this, we have a new histamine blocker coming that's a nanoparticle of quercetin, DIM, and luteolin that will block a lot of the food allergies that the people are getting, because they all have this immune dysregulation where they're becoming allergic to everything. And so that damps a lot of that inflammation. A little PC to move a little bit of bile. If they can handle the bitters, and you give them that, that's just dumping stuff that's already in there. That's just draining stuff that's in there, and you come in with the binders right after it to pick it all up. And you're picking up a lot of the mess that's being generated in the GI tract. A lot of people are afraid to use binders with food because they think that they'll be now malnourished within 3 hours, which is ridiculous in our society. And instead, when people feel really crappy after they eat, it's because all that bacteria is eating all their food and making all kinds of crap. And the binders will actually pick up a lot of that crap and pick up a lot of the endotoxin. And charcoal in particular is a fantastic binder for endotoxin, so that never even goes in. So when we say intestinal detoxification, it's really having those binders, moving them through the GI tract, taking a lot of the stuff out of the GI tract. And then, so there's that, there's slowly bleeding out bile. And you have to separate those two functions there away from cellular detoxification, where we're mobilizing out of tissues. And that's when you're using NRF2 upregulators. NRF2 upregulators are, you don't bring them in the beginning. You move those back up the line of your arsenal until you get that liver, gallbladder, GI path harmonized and working. And when you do, they'll start feeling better. You'll start lowering the levels in the blood. And once you get that and you've established some ground, then you go with NRF2 stuff. Because if you do that early, again, it's going to dump all this stuff into the blood, and it's going to have nowhere to go.
I thought that nerve upregulator, well, for those that don't know, it's basically a transcription factor that upregulates like what, catalase, superoxide dismutase, and something else that what was the other thing?
No, it upregulates a lot
of things.
It's upregulating glutathione synthesis, glutathione as transferase, and those two together are what kind of start moving the stuff out of the tissues. And then there's a phase 3 transporter at the cells. So the NRF2 is turning up the cellular mobilization from the cells out into the blood. And we've seen this, we've done a lot, because we have the Mercury testing in-house. When we really turn up NRF2 upregulation using lipoic acid and some polyphenols, you'll see the blood levels of mercury go up first in some people. When the movement from the tissues into the blood is faster than the clearance by kidney and liver, you'll see the blood levels go up. And then when you stop doing it, they'll go back down, and they'll go under where they were before. We've seen very clear signals of what I call tissue squeezing into circulation. But the bitter seems to be turning up phase 3 in the liver and kidney without turning up the tissue mobilization.
Okay, so that is completely naturopathic, what you just said, because we have always said, okay, we have got to sort of clear out, you got to sort of clear out the basic stuff before you start really mobilizing. And this is where sort of matrix, extracellular matrix work comes in. And I think because this is where a lot of the homotoxicology products I find can be really helpful in improving sort of the gentle detoxification and preparing the extracellular matrix for this exact phenomenon of tissue mobilization. So just a quick going back to the binders, because I actually have a lot of points that we can't go back to now. I have too many questions, but so it's like, let's kind of myth bust, just to keep it relevant for those practitioners. So like, in terms of what they can do, because I know that, for example, I'm not sure if some of your products would be available for Australian practitioners. I know that you do have some formulations through Bioceuticals, but I'm not sure about the binders, for example. I got something about a universal binder, and I was like, great, I love it, I'd like to try it, and can I get it from my patients, or do they have to order it themselves, or what?
Yeah, we haven't. Our universal binder, we call it Ultra Binder, and we just released it, a month ago, and it's going crazy. Everybody recognizes the need, and we have not lined up to sell it through Bioceuticals yet, so they'd have to get it from us. But you can make, if you can get IMD, and you can get charcoal and clay or the Toxic Prevent. And so charcoal, clay, or zeolite, IMD, those are the cores there. And then something, I use a lot of acacia gum. I use powdered aloe. You need some stuff in there to soothe, or else it feels like it's biting at your GI tract. So you could mix it into aloe gel. I just use the freeze-dried because I'm trying to make a powder. But any gums or things like marshmallow root or slippery elm.
Slippery elm would probably be good, because that's sort of borderline. A lot of those things that you mentioned, I think a lot of practitioners would feel hesitant to use with their SIBO patients, because some would get a flare-up from just the polysaccharides, for example, in aloe.
From aloe.
Stuff like that.
Yeah, that's why the acacia gum's so nice. It's a very slow burn, and it's bifidogenic. It's happening more farther down the GI tract. It doesn't just like light on fire right when it hits the intestine. So let's say powdered slippery elm and charcoal and zeolite, and mix those up kind of equal amounts, charcoal and clay.
That's bentonite clay, you said? Yeah, sorry.
Yeah, bentonite clay or the zeolite. Toxic Prevent is great. I like that one. But, our dosage of everything mixed together, and that includes our dosage of everything mixed together is about a rounded teaspoon, but half of that is acacia gum.
Okay.
So our dosage is only about a half a teaspoon of a blend of charcoal, zeolite, and it would be about half a scoop of the IMD. And then we'll have them do that several times a day, about 30 minutes after the bitters and the PC. So you can get the PC and the bitters. There is a bitters blend, but it's not long for the world in Australia. And if you want to make a blend of bitters, I use Myrrh is incredibly important. It's the most important one of them all. And then I use gentian. Yeah, why? Myrrh is the bitter detoxifier in Ayurvedic medicine. They use it the way we would use a real strong bitter detoxifier like golden seal in Western eclectic herbalism. So it's very strong bitter, and so it's hitting all the bitter receptors, but it's also a very strong chi mover and blood mover in Chinese and Ayurvedic medicine. It's moving stagnation, and it's a very strong antimicrobial. It is super important.
I'm actually experimenting with Myrrh a little bit for methanogens, but I thought that you have to sort of like be careful with Myrrh and not use it ongoing, like with my people hear me talk about
they worry about it in the kidneys, but I think the dosages that we're doing are not a problem. If you're jamming a whole bunch into capsules and taking grams and grams of it, you might have that problem. But you're going to take a tincture, it's like 80% Myrrh, and you'll use like one part of that and then like three parts dandelion extract and 3 parts solidago and maybe 2 parts of gentian if you have that, and that'll make a very strong bitter. You'll taste it. You want them to taste it, and it'll really do a good job for you.
That's great.
I'm being very nice in divulging the keys to many kingdoms here.
Well, I mean, look, they hear me talk about like I talk about my bitter formula, which is basically it has dandelion, Oregon grape, gentian, and Bakel skullcap. And so that's a formula that I recommend. Like most of the time, I'm like, just go on bitters. And so the old naturopaths used to say that, you know. I remember, like, I think it was Bill Mitchell who told us, like, you just, you know, you basically, that I think it was Dr. Bastier who told him, you just basically give bitters to everyone and just have them come back in 3 months and see what's left of their problems. So, but actually,
what's left. I see so many things change from it. I think that it's opening up the bile. I think it's closing the ileocecal valve or regaining its control. I believe that it works strongly on the kidneys, and I do put the solidago in there too because I do mercury work, so I'm always worried about the kidneys. And I would say take what you have and add myrrh to it. And and I can't be enough of an evangelist about the bitters. We have a new one coming out called Bitter X, and we have our older one, and they're just 2 different strengths.
The Bitter X, that's funny.
Yeah, Bitter X, man, that's the hardcore stuff. That's the one with the strong. That's the one that like boom. And because I was finding all these cases, and especially women, where I just couldn't smooth them out until I got that Bitter X in there. And then they're finding that their cycles are smoother too. And there was a lot of discussion from naturopaths and Chinese medicine about gallbladder and hormones. And then I come to find out there's bitter receptors on your ovaries.
Yeah, I've heard about that since about a year or so. So, but it's not like they're going to start salivating your ovaries. You're going to, like, what is the purpose of the bitter receptors on the ovaries?
I don't have to know. I know it works. And I'm a PhD. All right. I don't. One day we'll know, but it's freaking plain as day.
Yeah.
You treat enough women with bitters, you're like, my God, this is great.
So I have a little caveat to the bitters, and this is a little teaching point for practitioners, and that is if they're hydrogen sulfide dominant, right? Because of 2 bacteria, desulfovibrio and Bileophilia wadsworthia, and they actually are they're bile-loving bacteria. So sometimes when we see people that are eating, a ketogenic diet or high meat diet or high just fat diet, and they have high levels of hydrogen sulfide, then bitters can be a problem, or anything, cholagogues can be a problem because you're actually increasing bile flow. So that's the only caveat.
That's why you need the myrrh in there.
Yeah, well, yeah, and yes, you are killing them in the active phase, but some people, I've just started to look a lot more besides SIBO and treating SIBO. I'm also looking at large intestinal microbiome content through PCR methods. And so really getting down into the nitty-gritty has just been so rewarding, really, because you learn so much. But getting back to, I want to do 2 more things. We have about 20 more minutes, and I want to do 2 more things. One is I want to talk about biofilm and this whole idea of, that mercury is stored in biofilm. And then I kind of want to talk about mercury testing and what you offer there at Quicksilver Scientific. But before we do that, I want you to myth bust the charcoal absorbs all of your minerals, So this is something that we're always cautious as practitioners. Don't use too much charcoal because it'll absorb all of the minerals out of your food. Is there truth to that?
No. If you take tons of charcoal with your food all the time, it is going to take fat soluble vitamins. It's not really a mineral binder at all. So it would be vitamins it would take out. And when people are really have a bad GI and they're turning their food into toxins, well, what are you most worried about? I'm most worried about the toxins that are being formed in the small intestine and all the endotoxin, and I want to block that. It's not forever that they're going to be taking binders and food so close to each other. And if they're not taking it close to each other, you're not sucking these things out of the blood.
Good point. Okay. So generally, also, would you say that charcoal is or is not a really good endotoxin binder like LPS?
Fantastic, very specific endotoxin binder.
Okay.
Better than clay.
Okay, great. And what's your particular dose if you were just to use charcoal for a period of time?
Oh, just charcoal alone. I do 2 to 3 grams, 2 to 3 times a day. You can go to higher doses, but that's what I'm using as a total binder. But see, the thing is, when you use one binder, you have great specificity on some toxins and really bad specificity on other toxins. So the way you make up, and what that means is a small amount of binder will get a lot of a toxin that it has good affinity for, but only a little bit of a toxin it doesn't have good affinity for. So you have to make up for that by taking lots and lots of the binder. So if you're only taking one, maybe it would be 3 to 5 grams 2 to 3 times a day. But in the blend, if half of what we do is acacia gum and we're doing about 4 grams, that means we're only taking about 2 grams of total binder 2 to 3 times a day. And at certain times we're taking more. But if it was just charcoal, somewhere from 2 to 5 grams, according to what they can handle, what's not constipating them, and doing that a couple of times a day in the active phase of cleaning things out.
Okay, great. So let's move into biofilm, because this is a big hot topic with SIBO and stuff. So tell me everything about biofilm. No, I'm kidding. So, there's this thought that once you start to disrupt biofilm with the various disruptors, that all of a sudden it's like Pandora's box because you have metals in there that are going to be liberated. Can you talk about that?
Yeah, I'm not really... We haven't really directly measured that that's the case. And if it is the case, it's not going to be for mercury. Some of the early work, like Andrew Usman did a lot of work on that in autism, and they were talking about metals cross-linking polymers in the biofilm. And those would be metals that would be more like lead, cadmium, copper, iron, because they form those kind of bonds. Mercury doesn't do that. It's not a cross-linker. But when there is a biofilm, the biofilm will be covering a lot of the chemical transport mechanisms that move toxins from the blood directly into the small intestine. Now, most of the metals are going to be moving through the bile tract, but some of the stuff is moving directly into right into the GI tract. I think more of the hell that breaks loose when you disrupt biofilms is that the immune system wakes up and is like, oh my good Lord, look at all these bad players. And you have this huge flush of immune activity that's creating this very high inflammatory state. And in fact, one of the reasons that there is an overlap in belief on, or let's say some misunderstanding about what's metals and what's infections, is that EDTA is a fantastic biofilm breaker. And when, I know from our liposomal EDTA, when people take a lot of EDTA, a lot of them will get really tired and they'll be like, whoa, I'm detoxing metal a lot. But it's hard. A lot of that is breaking biofilms that are in the cardiovascular system, the vascular system. The plaques of the vascular system are actually biofilms. And when you strip those down, the immune system wakes up and inflames and starts clearing that stuff out. And so EDTA is very good, and I like it a lot for clearing out vasculature. It's one of the reasons it's so good for men for erectile dysfunction. It's a little hard to say how much of it is moving cadmium and lead out of the prostate and how much of it is breaking up the biofilms in the vasculature to the prostate and the erectile vasculature and increasing blood flow there. So I'm wandering a little bit off topic from the GI tract, and that's because I'm in the biofilm. You have this overlapping of things. Yeah, there's some metals there. Yeah, there's all hell that breaks loose. Is that because you released a whole bunch of metals in there, or is that because you exposed all these microbes to the immune system and the immune system's wreaking havoc? So I'll throw the ball back to you.
Okay. All right. Well, let's leave behind the biofilm and talk about what you are renowned for, which is the Mercury test. And so I have a few questions about that, and I don't know if we'll have a lot of time to go into all the evils that Mercury does, but we know it affects mitochondria and your thyroid, and it's toxic in so many different ways, neurotoxic, etc. And so, not specifically related to SIBO, but we do see a lot of chronically ill patients. And so my first question is, when do you feel it's good to test somebody for mercury? If they, for example, have had their amalgams out and they don't eat a lot of fish, is it even worth testing? That's one question I have. And another question is, let's kind of start with that and tell us a little bit more about what makes your test different.
Yeah, so the test is a mixture of testing load, how much is in there, and it's also a functional test, looking at urine to blood ratios, urine to hair ratios, to look at how the transport systems are working. And the most important of that is the urine to blood ratio for inorganic mercury. It's showing you if you have shut down transport in the kidneys, not just for mercury, but for all the things that would move through that MRP system. And it is my belief that when that's shut down, a lot of people that shut down in have upper GI issues, either parasites or SIBO, that's contributing to this endotoxin load that's shutting that down. So I'll often say, well, look to the GI when you see these kidney problems. And that's another old naturopathic thing. Kidney problems, look to the GI tract. And again, let's just, to close that loop, look into the block from the liver to the GI tract. When that's blocked, then toxins go from the liver back into the blood to go to the kidneys, and soon you overload the kidney paths. So by opening up the liver, gallbladder, GI flow, and getting that toxin flow going right, you take weight off the kidneys. That's why healing the GI tract can heal the kidneys, because usually healing the GI tract is helping the liver too. Now, secondary is, when is it good to test, when is it not? If you're looking around for what problems might be causing things, and they have fatigue, anxiety, you can't figure it out through other problems, always look at mercury, but only if they have some sort of history of exposure. Are they eating fish? Do they have amalgams? You asked specifically, if they had amalgams a long time ago, say 10 years ago, and they don't eat any fish, is there any point in testing? Well, then, no, it's going to be, mercury may be lodged in some of the tissues, especially tissues that are inflamed, like if you have inflamed thyroid, you can hold tissue, you can hold mercury in your thyroid. And it'll be very hard to see in this blood urine hair ratio, and provoking it won't help you anymore. Doing a challenge isn't going to help you any more than looking at it directly. But if they still do, say they had amalgams and they still do eat fish enough that there's a mercury signal in the body, then it's worth doing the test to see what the disposition of it is. What's the urine to blood ratio? How is it changing from methyl to inorganic mercury? You're getting a picture of how toxins are moving inside the system. And a lot of those disruptions to the toxin flow are started when they have amalgams, and they continue after the amalgams are taken out if you don't do any detoxification. Now, when we look at what amalgams do, the evil of amalgam is more than the mercury that gets in your blood. The mercury that gets into your blood is from what you inhale that's evaporating off of your amalgams. But then you swallow an even greater amount of mercury, and it's lining the GI tract, and it's changing the nature of the GI tract. It's controlling which bacteria like to live there and which don't, so it's changing the flora in the bacteria, but it's also creating this massive concentration gradient that your detox system has to move against. So it's trying to pull mercury out of the blood and push it down into the GI tract, but the GI tract is already filled with all this mercury that you're swallowing. And I believe that that trains the liver to dump more back into the blood towards the kidney and focus more on the kidney. People who have amalgams say that, you know, they have to pee a lot. And once we take them out and we work this GI binding in the GI tract and work those liver pathways, they find that they don't have to pee so much at night. That means you're taking weight off the kidney and redirecting it back through the appropriate liver, gallbladder, GI pathways. And that's a real big focus of what I try to do now, is really open up that pathway. And we find that that really helps the kidneys out a lot. So the point there is that having amalgams pushes you away from those liver pathways towards kidney pathways, and that can be seen in the mercury test. And as long as there's some throughput of mercury going through from some fish you eat or some other exposure, you'll see that you'll see some of those pathway blockages in the mercury test.
And so, you know, and one of the things that I also remember from your presentation is that because I was trained in a different way in terms of chelation and things like that. But really what you're doing is not so much chelation, but really using the PC or phosphatidylcholine and using all these different techniques to encourage the movement of mercury rather than, and then using binders, et cetera. Is that right? You're not really using anything that like a chelating agent.
Well, your body has a chelating agent. That's the point. And everybody said, no, glutathione doesn't work on its own. And glutathione doesn't work on its own. Glutathione works with glutathionase transferase and the transport proteins to take mercury and move it out of the body. It has always been the way that the body works. And certain things shut that down, and like inflammation, and then the mercury builds up in the system. The chelation goes and it shunts that whole natural system, and it binds mercury to different chelators that are water soluble and go out through the kidneys, and it's flushing things out through the kidneys. But there's a ton of misconception in the understanding of chelation. And the biggest misconception of all is thinking that the chelators are going into the tissues and taking the mercury and moving it out of there. They are not. There's some evidence that possibly, maybe, sort of, kind of, could be that some of the DMPS gets into the cells and gets some out, but DMSA absolutely does not do that. So where are they working from? They're working from the blood. They're binding mercury that's already in the blood, and they're flushing it out through the kidneys. And then you need the body's own mechanisms. That's conjugation of mercury onto glutathione and movement out through MRP1 across the cell membrane into the extracellular matrix and then into the blood, where it can then be caught by the chelators. And the chelators probably are going through lymphatic circulation a little bit too, but they're not going into the cells. And so you look at like the Cutler theory, and he used DMSA and DMSA and lipoic acid, and he thought that lipoic acid was a chelator, but all the data shows that lipoic acid is upregulating these aspects of the glutathione system. Formation of glutathione, glutathionase transferase, and then that movement of that conjugation through the phase 3 transporter at the cell membrane out to where it can be grabbed by the DMSA. And how does he stage it? You start with DMSA to lower the blood levels, and then you add in the lipoic acid, which he said would go into the cells and chelate. My contention is that the lipoic acid upregulates the dumping from the tissues out into the blood, and then DMSA is getting out. Now, he totally ignores the emunctories, he ignores the liver, ignores all that stuff, and that's why it takes these people 2 years to get better. When you line up all the drainage and then line up all the phases of detoxification, that's the body's chelation system, you can get people better in 3 to 5 months pretty easily. Really, really sick people, you got to slowly take them through it, and it might take them longer. But you get people better faster this way. And I've had a lot of guys who are DMPS 30-year veterans switch over to using our system side by side and said it works as well or better than DMPS. This is what I'm bringing forward, is a lot of the new biochemical understanding, and then a lot of it is just showing us how a lot of the old naturopathic stuff works. And whenever you know mechanism for how stuff works, you can more effectively use your tools. And so I'm bringing together new biochemistry and old naturopathy and newer understanding of older naturopathy, and lining up all the parts of the body so that it can do it. You don't need the chelator, except I believe you need some EDTA.
Well, I mean, getting back to the old naturopaths, it's like, we used to do all sorts of things like hydrotherapy that really increased the lymphatic flow of the gut. And there was no doubt that is incredibly effective in aiding everything you've just mentioned. So, and that's also a totally lost art, That's
absolutely
a lot of those things that we know worked, and we sort of departed as naturopaths and sort of losing on some level our identity because it's sort of being merged with functional medicine, which I'm staunch naturopathic practitioner that is, that's where my passion and my heart is.
Yeah, and look, you're using genomics tools, you're using testing, but you're not losing sight of the naturopathic framework. And there is a danger of the wannabe MD thing with the naturopaths. I hear them getting mad at me now. Where they're losing. We're losing that, and that they're a great tool, and where they will be better than functional medicine MDs is when they use their old tools with their new tools. Because, the hydrotherapy is huge for the lymphatics and the extracellular matrix. And where does that, you got to get it out of the cell, through the extracellular matrix, into the lymphatics, into the blood, then out through the liver into the stool, or out through the kidneys into the urinary tract. And some of those are traditional tools, and some of them are just new takes on what old herbs and nutraceuticals do.
Amen. Moving on, we're gonna wrap this up, because it's a Pandora's box. I could talk to you for hours about that whole aspect and the issues that this profession faces. But just kind of touch, I know that in Australia the try test is, I think, available through NutriPath. But one question I had for you was also, do you also recommend testing other metals? I certainly want to know if, especially here in Australia, there's an issue with lead and aluminum in certain parts where that's being mined. And so, would be great to get your take on the best way to assess other toxic metal.
Yeah, so NutriPath also has our blood metals panel, and there we do a whole blood assay for nutrient and toxic metals. It's sort of a broader map of metals in the body, and for the toxics, it has arsenic, cadmium, lead, mercury unspeciated, which is sort of, if they eat a lot of fish, you can see how high the levels are getting, and then there's silver and cobalt in there, and strontium in there as well as toxics. But then in the nutrients are super important in the map of the metal disposition. You've got calcium and magnesium, and you're looking at their total amounts and their ratios. You see in inflammatory situations, high calcium, low magnesium. Copper and zinc, really, really important. When you start getting excess copper and low zinc, copper becomes synergistically toxic with all of your toxic metals. You've got the cofactor metals, lithium, molybdenum, selenium, Manganese, and manganese both as a cofactor and when it gets high as a toxic. So that one blood analysis is showing you the status of a lot of different metals together. So it does give you a good overview.
And so whole blood versus intracellular.
Yeah, intracellular. Don't think that red blood cell means intracellular. That means spun down blood. And for some things that might be better, and plasma might be better. For a whole map, whole blood is better.
Whole blood, okay.
Intracellular, what they mean when they say intracellular is what's the company that does that? SpectraCell.
Oh yeah.
SpectraCell tests are cool, and they're using lymphocytes and sometimes looking at metals in lymphocytes, but mostly what they're doing is doing intracellular sufficiency of nutrients. And so they'll put them in a nutrient medium that has everything except magnesium. And if they die really fast, then they say that the intracellular store of magnesium was really low. And that's a very interesting test. But when people say they're measuring intracellular cadmium because they get red blood cell, that's just stupid stuff that they're just saying.
Okay. So, but I thought that like when you're measuring whole blood, there's certain elements and like metals that have a half-life of not very long, and so you might not capture certain toxic metals, or do you disagree with that?
And so then you just take that further, then you're saying, well, I want to know the intracellular levels, so that means you do biopsies?
Good point. Well, isn't that like an intracellular storage, though? I mean, I understand that having cellular toxin, like they're really tucked away sometimes.
Yeah, and we'll get into that for a second, but I want to take this story further because you'll see that it goes nowhere. So how do you measure intracellular stores?
By looking at intracellular levels. No?
How are you looking at intracellular levels? What cells are you using?
Red blood cells.
Red blood cells aren't cells. They don't even have a nucleus. They're not cells, all right? They're oxygen transport mechanisms.
Okay, this is true.
Certain metals partition inside the red blood cells, and certain ones stay in the lymph. It's just according to their nature. It has nothing whatsoever to do with what's going on in the rest of the body, because red blood cells are not cells. They're little transport things. And just by their nature, some stuff is in it and some stuff's outside of it. Like methylmercury is 95% inside the red blood cell or associated with the red blood cell. Inorganic mercury is half and half between the red blood cell and the lymph. And we measured this stuff up and down. It has nothing whatsoever. The disposition there has nothing whatsoever to do with what's intracellular or not. So this is just people using a test and putting a story around it and saying it means something. There's always a spread between lymph and red blood cell that has so much more to do with the nature of the metal than it has to do with toxicity in that person or not.
Okay.
So the other thing is residence time in the blood. So residence time. So for mercury, there was always this game that was played that the half-life of mercury in the blood is 2 to 3 days, and you'll never see it. Now, it was totally made up to sell challenge tests. And when all the literature from back to the 70s has always said that the half-life, depending on the study, was between 45 and 70 days, depending on the form in the study. It's a really long time. And there's always this distribution between the tissues and the blood. The blood is at a steady state with the tissues in general. The 2 to 3 day thing came from if you and I went out tonight and ate swordfish, a really high mercury fish, we would digest that. It would be associated with cysteine, an amino acid in the tissue, would go into our blood. It would peak in about 12 to 24 hours, and it would take 2 to 3 days to distribute into the rest of the tissues. And so there is a transient peak of 2 to 3 days, but then after those 3 days, to go from our next baseline in the blood back to before we ate the swordfish would take, in a healthy body, at least 160 days. So this 2 to 3 day thing was just made up so that we can say blood's no good. We have to all do these urine tests. But then we see the urine test could be no good because the transport mechanisms could be broken. So we want to look at a combination of all these things. Now, is blood always a perfect marker of all the tissues? No, because certain tissues have this ability to they get sick and they hold on to the toxins. Now, part of that mechanistically, we can say inflammation turns down detoxification. So if we have Hashimoto's, we can expect that our thyroid is going to collect and hold on to mercury and cadmium and arsenic and lead. And yeah, okay, we can go with that. But then there's all this stuff we just don't understand yet. You follow those guys who are doing neurotherapy and the Klinghardt school, and they give psychotherapy to somebody, and all of a sudden they release a whole bunch of metals. There is a bunch of nonlinear stuff we just don't understand. But within the linear world where it's all supposed to be behaving, blood is at a steady state with the organs.
Okay. Well, that's a whole, you just, at the very end, you open up a whole nother box of the nonlinear state. Okay, well, clearly you have to come back. Now, let me just I'm not even going to attempt to summarize all of this, but I encourage practitioners to look at your YouTube channel. All of your details are going to be in the show notes. But I've learned a ton here today, and I'm hoping that people really heed the call to respect more these emunctories and learn to, or look where you can learn more about this, because I think it's a really important piece, not just for SIBO, chronic gut issues, but really chronic health in general, health conditions in general. Now, any last minute pearls of wisdom from you, Chris?
Yeah, if we just summarize all that, one of the ways I teach detox is there's drainage and mobilization. Start with drainage, and that's lowering circulating levels. Focus on kidney, focus on liver, GI, lower the circulating levels before you go to mobilize. And that's when you're using lipoic acid and sulforaphane and polyphenols. Save them for later, get the levels down first with good drainage. And that could be herbs, it can be the binders, it can be homeopathics. Homeopathics are more gentle, herbs are more aggressive, but drain and then move out of the tissues.
Fantastic words of wisdom from Dr. Chris Shade. Thank you so much for a wonderful hour of diving into some of these mysteries of how to deal with these patients. Thank you so much, Chris.
You're welcome. That was a lot of fun.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Head over to our sponsor, SIBOtest.com, an online testing service for your patients and home of the Practitioner Education Portal. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.